In the world of clinical ECG interpretation, things are rarely as neat as they look in textbooks. Small deviations in morphology or external interference can lead to misdiagnosis, potentially resulting in unnecessary interventions or missed emergencies. Here is a breakdown of the three most common ECG confusions and how to tell them apart. Pacing spikes versus narrow QRS complexes. Large unipolar pacing spikes can be confused with normal QRS components. Conversely, sharp artifacts can sometimes look like pacing spikes to the untrained eye. The confusion: a ventricular paced rhythm often creates a wide QRS complex that can be mistaken for a spontaneous bundle branch block. If the pacing spikes are micro spikes, you might assume the patient is in natural wide complex rhythm. The differentiator: pacing spikes look for a perfectly vertical, nearly instantaneous line preceding the QRS for ventricular pacing or P wave for atrial pacing. They occur at a metronomic fixed interval. Intrinsic QRS will have a sloped R wave or a Q wave start even if it is fast. Clinical tip: if you see a wide QRS with a left bundle branch block morphology and a vertical line before it, always assume a pacemaker is present until proven otherwise. Artifact versus ventricular tachycardia. This is perhaps the most dangerous confusion in a hospital setting. Toothbrush tachycardia or patient movement can create waveforms that mimic life-threatening arrhythmias. The confusion: repetitive movement, shivering, brushing teeth, or a loose lead can create large, wide rhythmic deflections that look remarkably like ventricular tachycardia or ventricular fibrillation. The differentiator: the marching R wave. Look closely at the rhythm during the arrhythmia. In many cases of artifact, you can see the normal underlying QRS complexes marching through the noise. Lead check: if the VT quote unquote is only present in lead 2 but lead 3 looks like a normal sinus rhythm, it is almost certainly artifact. True VT will usually be visible across multiple leads. Clinical tip: always check the patient, not the monitor. If the patient is sitting up and talking while the monitor shows ventricular fibrillation, check the electrode pads. Left bundle branch block versus mimics. LBBB is a classic ECG finding, but several conditions can mimic its appearance, leading to incorrect assumptions about heart failure or ischemia. The confusion: conditions like ventricular pacing, Wolff-Parkinson-White syndrome or WPW syndrome, and hyperkalemia can all produce wide QRS complexes with a dominant S in lead V1, much like a classic LBBB. The differentiator: WPW, look for the delta wave, a slurred upstroke at the beginning of the QRS, and a short PR interval less than 120 milliseconds. Hyperkalemia, look for the sine wave appearance. The QRS will be wide, but you will also see peaked T waves and a flattening or disappearance of P waves. True LBBB requires a QRS duration of 120 milliseconds or more, a broad notched R wave in one AVL V5 or V6, and the absence of Q waves in those same leads.